surgery has changed, as I mentioned before. So it was a standard for most of the patients. In the beginning of this retrospective series that I touched on before, 60% of all the metastatic patients received surgery of the primary tumor, and this has gone down to 30-40% nowadays. And what people looked at especially was the kind of surgery. So you don't just take out the tumor, but many studies looked at how surgery was performed, when it was performed, what to do with the lymph nodes in the axilla. And the current guidelines reflect those findings from this series. They say, well, it can be done in selected patients. You have to discuss it in a multidisciplinary meeting, and then take those patients to surgery that could benefit, for example, those with a longer follow-up or longer interval between the first diagnosis and the metastatic diagnosis, and then the patients with more favorable biology, etc. In general, we have also seen that the survival of patients with metastatic breast cancer has improved. So when these series were published, the median survival was between 18 and 24 months. And now in a current series, for example, in a registry from Austria that comprises most of the patients from the largest tumor centers from 2015 onwards. And we have seen the median overall survival of 33 months at the moment. So it's considerably longer, ranging from 15 to 50 months, depending on the tumor biology. So it's very important to have the tumor biology and the stage and the number of metastatic sites in mind nowadays to really select patients who could potentially benefit, especially those with a favorable outcome, let's say survival that's 2 or 3 or more years. The other thing is that we want to go into, or we are going into, palliative surgery, and this has been a standard and is still a standard to take those patients with open wounds, with really problems with their tumors, so that we can avoid certain problems for local progression, for example.